The following Agios-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Welcome to Thal Pals, the Alpha Beta Revolution, the show where we share stories, insights, and conversations to empower the thalassemia community. I'm your host, NinaMaria Badalamenti. On this episode, we're talking about pregnancy and family planning, covering the unique considerations, challenges, and hopes for people living with thalassemia. From medical care to personal decisions, it's a journey that comes with a lot of questions. And today, we have hematologist Dr. Arielle Langer to help provide some of those answers for us. Before we get started, we do want to mention that we realize pregnancy isn't for everyone. We want to recognize every patient's unique experiences and acknowledge that there are many options for having children or not to have children, whether it be adoption, surrogacy, pregnancy, or none of the above. Now, without further ado, let's meet our guest. Why don't you start by just telling us a little bit about yourself and your background when it comes to thalassemia?
So, hi, NinaMaria. Thank you so much for having me today and talking about this important topic. I think it's a space where there's not enough data, so really learning about what applies to you, what we know and we don't know is going to be really useful. For me, I'm a hematologist at Brigham and Women's Hospital in Dana-Farber in Boston. Here, I run our thalassemia program, so I'm seeing all the folks with transfusion-dependent and non-transfusion-dependent thalassemia. And I also see a lot of folks who are trying to figure out their family planning journey for this and with my other hats. The other program that I run at my hospital is actually our women's health program. This is the overlap of the two things that I'm really passionate about clinically. And I think it's really important to not only acknowledge there are a lot of different ways to build a family, but that sometimes family doesn't mean including kids. So I think it's really important for people to make those decisions informed, for us to realize that this isn't the only way to build your world.
Yeah, and I do want to touch on something that you mentioned, which is why I've been really excited to have this episode. Just the fact that we don't have a lot of information out there readily available to patients with thalassemia when it comes to fertility, pregnancy, family planning. Why is that?
I think there are a few different things. First of all, a lot of folks in our community in thalassemia realize that 50 years ago, women with thalassemia weren't necessarily healthy enough at the time of reproduction. And we've done so much with transfusion and iron chelation to get people in just a really wildly different amount of health. So some of it is that having a person who's been transfused since childhood able to have a pregnancy wasn't something that a couple of generations ago was relevant. So one of them is the time frame. And the other is everybody listening today knows that in our community, we all know lots about thalassemia, but it's overall pretty rare. One of the things about it is just a changing culture about realizing that fertility and fertility-related things are really important for people's quality of life, and understanding that over time we've prioritized that more, but also that our thalassemia patients are healthier and it's more realistic over time. So I think it's some lack of expertise, some lack of focus, the rarity. I think the reason why there's so little data is because there were a lot of different factors pushing it.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, patients, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on hemolytic and acquired anemias, including sickle cell disease, pyruvate kinase or PK deficiency, and thalassemia. To learn more, visit agios.com. That's agios.com.
So I do want to set the stage of this interview by when you have your patients, your thalassemia patients come to you, either male or female, and they say, hey, I really want to have a biological child. Where do you start? What's the conversation you have with them?
To start with men, I think one of the things to keep in mind is sometimes there's some stuff out there about can you safely collect sperm if you're doing IVF or have issues with fertility with iron chelation. There's not really data that we should worry about that. And given that getting pregnant can be something that happens really quickly or takes a couple of years, depending on your luck, I strongly discourage people from stopping iron chelation if they're a male patient out of any fear or there. Maybe in the future, we're going to have data to say that's necessary, but we don't have that right now. And we all know that iron chelation is really important. The other thing that applies to both men and women is realizing that waiting to be on top of your care until you're ready to have kids is not a good way to go about it, because a lot of the stuff that interweaves thalassemia and fertility related considerations are all about hormone levels and things that relate really to your long-term, if for people who need transfusion, if you've been well transfused, and whether or not you're on transfusion, if your iron's under good control. One of the things when iron's really out of control is that the places it affects the body include a lot of the hormone systems or the endocrine issues. And so one reason people can have reduced fertility is that they haven't had good control of their iron long-term. So I think that applies to both men and women. But on the men, the conversation is almost really centered around, has your iron been good and are we staying on top of it? And if we've done those things, then we probably controlled the piece that's related. On the women's side, there's a little bit more to it, because we know that from the data we do have, women with thalassemia tend to have their ovarian reserve. So that term for like how long your eggs are good for, at what age you stop being able to like make good quality eggs, it's less, and it tends to be something that happens at a younger age. And so I think culturally, it's extremely normal to not be thinking about getting pregnant until you're 33. If you have thalassemia, it's not that we should be pessimistic for you, but if you're waiting until you're in the later chunk of fertility, you may have really caused an uphill battle. And so one of the things I actually try to do is bring it up maybe before people want to hear about it, and make sure that folks are thinking a little bit in advance about how they want to plan. The iron considerations are the same, but one of the other things that's really important in thinking into the future is that you can't take iron chelation medications at all in the first trimester, because they can mess up the organs growing when they're all forming. And we really try to make it as late in pregnancy as possible, which means that it's not just about being under okay control. In an ideal world, you have that control really good, so you have room to spare, so that when we pause it, you don't end up having a lot of issues during pregnancy. There are also a few other specialists that need to be involved in making sure that other parts of your disease are under good control to be as healthy as possible going in.
That was an awesome answer. So jam-packed, full of so many things I want to touch on. So let's break it down a little further. You did mention age. So what does that look like for women? I believe healthy women, 35 is that line of geriatric pregnancy. What's the good age for women with thalassemia to be really like, okay, we need to really think about this?
So for anybody who hasn't heard it before, geriatric pregnancy is actually considered a medical term. One I am not a fan of, because I'm over 35 and I do not especially like being called geriatric. It's a dividing line. The line has to be drawn somewhere. And the idea is that we know that folks who are over that age are more likely to have trouble getting pregnant, or if they're using fertility services, more difficulty collecting eggs. There isn't really high quality data about what the right substitute number is. So I want to be humble that I don't want to spook anybody or make anybody upset by throwing out one that's not there. At the same time, it's definitely younger in terms of when we can expect to start to run into folks. And so I would say that if you are really sure that you want to have kids, and also really sure that you're not ready yet, it's not wild to think about doing egg freezing when you're at an age where maybe your friends that don't have thalassemia are not thinking about it yet. I would say that's not a crazy thing to be thinking about in your 20s. Just understanding that 35 is for people with nothing else, and that sometime younger, it's going to be an issue for people with thalassemia. So it's good to be thinking ahead if you're sure you want to have a family, so that you can mull over whether you want to do any fertility planning in your 20s to be an insurance policy if you're not ready to pursue it, but you're not sure what the egg reserve would be when you're in your 30s.
And I love that you touched on, specifically with your patients, you like to have this conversation sooner rather than later. I think that's something a lot of doctors may forget about. How you mentioned, a lot of them are based in pediatric care. I know a lot of adults still have pediatric hematologists. So I feel like that's something even me, I had to ask about, which you should take control and ask the questions. But, when you're diagnosed at 6 months, nobody's asking about, can you have children? I want to emphasize that for all the doctors listening out there. I think that's really important.
And I think it's super important to be your own advocate, because honestly, everybody here knows that there's not a thalassemia-focused doctor in every city and every place if you're somewhere rural. Like, that's not always realistic. So I think it's important to just be aware to advocate for yourself. And I try to ask because I don't think the average 23-year-old wants to think about this. And I don't have a long conversation with them about it. I just say like, hey, we should think about this earlier than you might otherwise think about it, and then leave it to them. Women are not baby-making factories. I'm not assuming that all my patients want to be pregnant ever.
Just a little heads up. So outside of age, is there anything else that we know about thalassemia and fertility? Any other connections?
Yeah, we do know that people whose iron is under poor control or was under poor control for a long stretch of time can have a harder time because it messes up a lot of the hormone cycles. And obviously, if you in the past had bad iron control, like the thing to do is get on top of it now, because the more under control it is now, the better. And trying to make sure that when you go through life stress periods, you don't let things get really out of control. I think this is one of the hard things is like you don't get to take a break from having thalassemia. So if you have a really stressful, you're in college or something else like that, you're just realizing that staying on top of your iron chelation is important. That said, it's not that if you're out of range for a few months, there's anything that's irreversible going to happen. But the number one thing that folks can be on top of in the long term is their iron control.
And obviously, this emphasis of iron control is like long term. That's something we're always focused on. Is there anything else for folks who know they want to have kids, just not yet, but they know they will in the future? Are there other things that they could do just to prepare their bodies in hopes to have a better outcome later on?
Yeah. So in terms of preserving fertility, there's nothing else that's data driven. So there aren't, in some ways that's nice because there aren't 17 things to keep track of. In terms of preparing for pregnancy, the other thing to be really careful about is that you've stayed on top of the cardiovascular care. In TIF guidelines, you're supposed to be getting some cardiac assessment at least every 2 years. And some folks locally are doing it with an echo, some are doing it with an MRI and substituting that for echo. I'm not going to get into the weeds of that, but the screening for cardiac health is really important because that is one of the systems that gets majorly stressed by pregnancy, and your risk of becoming pregnant are super different if your heart's in tip-top shape than if you have issues that haven't been addressed. So a classic example of one that we're very worried about not being on top of before pursuing a pregnancy is what's called pulmonary hypertension. And that's when the pressures going to the lungs are at a high level. That's something that for people who are not on chronic transfusion and have thalassemia intermedia, it's one of the complications that might prompt us to say, you actually really need to be on transfusion now. Not because of the pregnancy, but because of controlling the pulmonary hypertension. And that would be a classic example of something where I would strongly want someone to get on top of that and have that under control before, because it puts you from a mildly increased risk of being pregnant to all of a sudden a very high risk pregnancy. And so I would say making sure you've done your heart screening and that if there's any sign of pulmonary hypertension, it's addressed before getting pregnant is my number one.
So now when it comes to pregnancy, it's time, you get pregnant. What do we need to know about any complications specific to women with thalassemia?
So I'll divide them two things we need to do for mom and things we need to do for the baby. The first thing for mom is that if you're trying to get pregnant, keep track of your cycle, do something to figure out, because you're not supposed to be taking your iron chelation early in pregnancy. And so it's pretty important to be recognized very early on if you're pregnant. Now, if you're doing IVF, fine, we know exactly when to stop your meds. But if you're getting pregnant on your own, it's important to be doing something to keep track of your cycles and identify it so we stop that early. The thing we don't want to do is have somebody just totally go off their iron chelation again for months at a time, because it can take a while to get pregnant, and then that puts you at a different risk. And so I would say when you're prepping, make sure that you have talked to a doctor, made a plan that works for you and the method that you're trying to use to get pregnant to make sure that you're not on it early on. That's one thing, and that's balancing the risk. Then during the pregnancy for mom, we need to keep an eye on the iron levels. It is okay, and there's a lot of reports of using the iron chelation infusion as a pump, not the pill forms of iron chelation during pregnancy in the latter half. And so we want to make sure that we're not letting mom take a risk and get it really out of control iron levels by tracking during pregnancy and keeping in mind ferritin, which is what everybody's measuring month to month. You can draw in pregnancy and be fine. And MRI, if you need to get it, you can get it just fine. It has zero risk for the pregnancy. So we can use our standard ways of monitoring. The other thing that's going to be important for keeping mom safe is transfusion. The overwhelming majority of women with thalassemia or pregnant have their transfusion requirement go up. So that might mean somebody is not chronically transfused before, and now they really need to be to maintain safe levels during pregnancy. And the other is that if you are transfused, you can expect that you'll either need to get more units each time you go or go more frequently. And I think that's important to plan ahead, because if you are trying to be pregnant and make the rest of your life work, realizing that you're going to have to budget more time for your transfusion trips, I think is really important practically. On the baby side, managing how anemic, so how low the hemoglobin goes, is the most important thing to keep in mind. So not letting the iron chelation exposure in those first few months, and then really making sure we're hitting targets. And that's part of the reason why sometimes people who are not on chronic transfusions before pregnancy, even if their levels are only a little bit lower, are really encouraged to hit higher targets like 9.5 or 10 during the pregnancy. And that's both about protecting mom and about making sure that delivery of nutrients to the baby are adequate.
And when it comes to the chelation early on, obviously, ideally, we want this to be planned and prepared, but accidents happen. Is that...
That's life.
Yeah. What, is it okay to stop as soon as you find out that you didn't know early on? Obviously, we want to mitigate that, but if it happens, is it okay?
Yeah. So it's not a guarantee that anything has gone wrong. And it's certainly, if there was like one dose, nobody should be panicking. Share that with your doctor so they can do a careful look over on the early ultrasounds and tests to make sure there's no evidence that something bigger has happened. But many people have that's what we call it, accidental exposure, is doctor speak for you took the medicine before you realized you were pregnant. And a lot of the time it's going to be just fine. I would say the moment you know you're pregnant, don't take the next dose, because iron chelation is never a day-to-day emergency in a scenario like that. And if you're somewhere where you can't take a pregnancy test for 2 days, hold still. Like, it's okay to miss one dose. If you've been doing a great job with your irons under control, it's totally fine to miss a day while you make it to a drugstore and figure out what's going on.
And then when it does come to getting the pump chelator later on in pregnancy, are we wanting to not have any chelators? Are there advantage to not having, or it doesn't really matter later on in the pregnancy as long as it is the pump?
So we don't have evidence that the pills cause harm later in pregnancy. We just don't have evidence. And that doesn't make us happy in pregnancy because it's such a short stretch and we don't want to take the risk. But the concern is that the same way that you can absorb the pills, that a lot of it may get across the placenta, and that's our concern. So for right now, I would never prescribe pills in a pregnancy. Maybe that's going to change in the future. We'll see. In terms of the pump, there have been a lot of reports, but they're reports, they're not huge studies, of people being on these chelators, the pump, like the one infused under the skin in pregnancy, and they're fine. So I think we always like to make people do the least stuff they have to do when they're pregnant. That is both for mom's sanity, because it's a lot to be pregnant, and also because of safety. And so we generally try to hold off until later on. And that's part of the reason why I emphasize this is a place to be planning ahead. If you enter with a really low liver iron concentration, we're not going to have a hard time, even with increased transfusion, getting you to the third trimester, and sometimes even getting you and dealing with it after delivery. If you enter out of control, we're going to have to start the second it's safe for the pregnancy. And if you enter on the upper end of control, we're going to have to balance, because we never want to let mom be at risk when we don't have to in that regard. So I would say if the idea of dealing with the pump stresses you out, which is really normal because it's not fun, that is a reason to try to push your iron to the very lower end of the goal range before getting pregnant, because then you may spare yourself ever dealing with it, and certainly you won't have to deal with it for too long.
And with this emphasis on ideally wanting to be prepared and plan it out, what are our options when it comes to preventing pregnancy? Is it safe for women without to use different types of birth control? Are there only specific kinds? What does that look like?
So I like to break the different forms of birth control, whether we're using them for pregnancy prevention itself or controlling periods, into 3 buckets. And those 3 buckets relate to ones with no risk of blood clots, very low signal for risk of blood clots, and the ones with the most risk, which is still actually overall a lower risk. The reason we care about that is that the interaction between thalassemia and those options is really about the blood clot risk. People with thalassemia have a small small increased risk of having blood clots. It's not big. It's bigger for people who have had their spleen out, although again, most people will still be completely fine on that front. And then there's certain medications that we use for thalassemia that also carry a blood clot risk. And so sometimes if you have multiple of these categories together, it influences what we want to pick for pregnancy prevention for you as an individual. So it's super important to circle back to your doctor and not take a generic, because you might also have something totally unrelated that it changes your risks too, right? You have thalassemia, but you still can have other stuff going on with your health. So the lowest risk options, the one with no proven risk, are either form of IUD. So that's an intrauterine device, which is like a little T-shaped thing that gets inserted into the uterus and then can stay in for years at a time. That comes in two forms, one that has some progestin, so a little bit of hormone in it, and one that uses copper. Neither of those has any association with blood clot risk. And so they're a really one and done way to prevent pregnancy for several years, and they work really well. The other form that has zero association with blood clot risk are the progestin only pills. And there's a few different ones of those, but that's the underlying hormone. So they're the pills that don't have estrogen in them. Oddly, the progestin shots actually do have a slight, and that's the one in that middle category that I was like, there's like a little risk. It's not zero that's there. And so that one we generally avoid, because you either really wanting the one with no risks where we have enough choices now, I don't use it very often, versus on the other end. So the ones that contain estrogen are really the ones to think about. They are the most common ones. If someone says I'm on the pill, that's what we assume that they mean. And they do a better job for some things. If you're having issues like acne or sometimes like mood swings, there are other things that they can help with for having the estrogen. So I really try not to just restrict everybody from this class of medicines. Can be really helpful, but they do carry some blood clot risk. So if you have your spleen out and are using a medication that also comes with some blood clot risk, we don't love then having three different things together that add to that.
So it's not really a one size fits all, something you want to have a conversation about.
It's not, because what if and there are other things like if there's a family history of blood clots and folks that don't have thalassemia in your family, then we're probably going to try to avoid that estrogen. And so then it leaves you with the IUD with or without hormones or pills that just don't have estrogen.
When it comes to the birthing process, I was curious, obviously that's like very intense. Can women with Thal go through the birthing process naturally? Is it more high risk? What does that look like for us?
So one of the things we want to keep in mind is that if you are coming in and you've had good care of your heart and you've had good control of your iron, like heading in, and your organs are all like functioning really well, then birthing for you is probably going to be basically the same risk as everybody else. You might have a tiny bit of a higher chance of getting a transfusion right after you deliver, just because you're starting out with numbers a little bit lower. And if you bleed the average amount, that might put you in there. But nobody with thalassemia is going to like really stress out too much about that transfusion. So I think the answer is birthing is intense. It can be a lot. But I don't think that selecting things like whether or not you're safe for an epidural, or if you can deliver, if you want to try to deliver at home, like as a doctor, that always makes me nervous, but it's the right choice for some people. And I don't think this necessarily has to shift the risks in someone who's doing well. Very different than if you're someone who's had heart problems or something else like that, where we might be worried about those things.
And then after post-pregnancy, can women with Thal breastfeed? I know we would go back on chelators potentially. Is that a possibility or not really an option?
Yeah, you can definitely breastfeed. There are a lot of benefits to breastfeeding, things like a slightly lower rate of breast cancer for mom in the future, that there are some positive associations for the baby. So we like to offer that to everybody. Having said that, sometimes we place too much emphasis on that culturally and make people feel really upset if they can't breastfeed in a way that's out of proportion to the benefit. So I am 100% saying breastfeeding is great and has health benefits, but I also don't want to feel like for the people that it isn't the right thing to do for them, or it isn't possible for them to do for them, don't feel like you've done something terrible for your health or your kids' health. I think I have to say that because I've seen so many people tied into knots about it, and really unfairly. And that goes hand in hand with the fact that you hit the nail on the head of what the issue is. Right now, we don't have data that's safe to breastfeed on oral iron chelator. So if you're going to breastfeed, you are stuck with the pump for your iron chelation. And I would say that if you've made it through a whole pregnancy, dealing with a lot of different things your body has gone through to bring this kid into the world. Sometimes it is just too much to deal with the pump and a newborn, in which case, like, the answer is to stop breastfeeding and to switch over. And that's sort of why I started with we should value breastfeeding, but we shouldn't overvalue breastfeeding, because it's just not a good thing for mom or baby if you are stretched too thin, because there are multiple ways that you can take care of your kid. Breastfeeding is one of them. But that was obviously, I'm very protective of my patients and how much people hassle themselves. The short of it is you can breastfeed on the pump form of iron chelation, but not the pills.
You got to make sure mom's healthy.
Yeah. And also, mom needs to be healthy for mom to be healthy. It's so important that the only frame of reference we use for maternal health is not in relation to being a mother. It is also important for you to be well for yourself. And yes, also, if you are an endlessly selfless person, you cannot take care of someone else if you are falling apart because we have stretched you too thin.
So how do you coordinate with your OBGYN, MFM colleagues to make sure that your patients are well managed through this whole process? And then my second half of that question is, how do you empower patients to do that if they don't have a hematologist who's as well versed as you are?
So I am very lucky. As I mentioned, the other thing outside of thalassemia, that's my other clinical passion, is our women's health program. And I get to work with an amazing division. I cannot speak more highly of the colleagues I get to work with here. They are so curious. So even if it's a rare disease, because nobody's going to have taken care of 15 pregnant patients with thalassemia, that's not like the statistics of how it is. Everybody is curious and collaborative, and I'm so lucky to have that. One of the things I think is really helpful for patients is that maternal fetal medicine, which is a synonym for high-risk OB, which, by the way, it takes very little to jump into that bucket, so you shouldn't be terrified if someone asks you to measure high-risk OB. It's basically everything but standard risk goes to them. All of those doctors are very used to doing what we call preconception counseling. So you can go and meet with that doctor before you are even trying to get pregnant to learn about what they would do to help you with monitoring, things like extra ultrasounds that we'll do to track growth, and to hear about that process, and also to get comfortable with somebody and see if they're someone you can feel comfortable talking to. What are the different sites they can deliver? Is it realistic for you to deliver at their main hospital? Are they going to supervise your care from further away because it's not realistic to drive when you're in labor? All those things. But I would strongly encourage folks to meet with an MFM beforehand if they are worried, because I think a lot of those worries melt away when it's a concrete action plan. They may not have taken care of someone with thalassemia, but their whole job is to be curious and engaged about other medical conditions. And they've definitely taken care of people who are just as complicated, of a different flavor, and of other reasons to be doing the extra growth scans and things like that we would throw in. So for that, I would say meeting that person directly will help. For people whose hematologist has not done that before, you can also get comfortable by talking to the OB folks yourself with the MFM group. For me, I know all of them. They're wonderful. And we send referrals in both directions for different conditions, including this one. So my answer is I can text or email any of them, and they're really going to just respond quickly the same way I do for them when they need help with their patients.
Is there any special consideration folks with THAL should know about when it comes to postpartum?
One of the things that I actually neglected to mention earlier is that one of the other complications during pregnancy can be getting blood clots. We talked a little bit about it in the context of birth control. There's a little bit of difference of opinion across different doctors about who should and shouldn't be on prevention doses of blood thinners during pregnancy. And some of that is, again, as we talked in the context of birth control, you will have individual things that tip you within the spectrum. And so I think that's a really important part of your pregnancy planning, is to talk to your doctor ahead of time about whether or not we might want to take that precaution to put you on prevention doses of blood thinner. Sometimes we only do it postpartum. And Maria, that's why your question prompted me to think back on that, because what's not at all intuitive is that the highest risk time to get a blood clot related to pregnancy is actually the 6 weeks after delivery. It's really not what people expect at all. But you have, even though it's only 6 weeks, it's the same number of events as happen in the entire pregnancy itself. So the day-to-day risk is meaningfully higher. So sometimes postpartum planning additionally includes saying you didn't quite meet the threshold to deal with the blood thinners during pregnancy, but we are going to put you on for those 6 weeks to make sure that your recovery is smooth. The other thing in the postpartum period is that you are going to be exhausted and it's going to be hard to tell apart what's you're more anemic and what's you haven't slept, because welcome to newborns. That's what they do to you. So I think it's really important to plan out ahead of time how you're going to get in for those checks and transfusions and make sure you have the supports in place with family to be able to take those times to make it in, because it can seem like it shouldn't be daunting to do the routine that you've been doing for years and years, but it can be with a new member of the family. And so I think that's really important.
And then I just want to touch quickly on genetics. What should potential parents with Thal know about genetics?
There are rare exceptions, but for most people with thalassemia, intermediate or major, so we know these kind of funny different terms we use, you have 2 genes, one from mom and one from dad, that had a mutation, which means you're guaranteed to pass one of those 2 genes on to your kid, assuming that you're genetically related kid. That is why it's really important to have partner screening. If you have a partner that has no gene copies, then the most that the kid can have is what we call thalassemia minor or thalassemia trait, which is something that's really not a concern, has very little implications for health, and is mostly just about education to know that it exists there. Doesn't require transfusions, doesn't have all of these other complications that we care about. So if the most that you can pass on to your kid is thalassemia minor, you essentially shouldn't be thinking about it at all other than to share with the pediatrician so they're not confused about labs. If your partner is a carrier or has thalassemia themselves, then we're in a little bit of a different bucket. If they also have thalassemia, you're guaranteed. If you both have only the genes that give you thalassemia, you're guaranteed to have that kid. What's more common is that your partner has thalassemia minor, so then you have a 50-50 chance. That is something that people have really different feelings about. Some people have lived with thalassemia their whole life. You've got your system down. You don't trouble you, and it doesn't bother someone to have kids that have the same thing, because you'll actually know exactly how to get them through it and be a really big support, and that's incredible. Other people feel really strongly about not passing it on, and those are folks who may want to consider doing IVF and doing embryo selection, which is the term for picking out which of the embryos don't have thalassemia and which do. I never weigh in on what is right for my patient, because that is not my place. People feel really strongly in both directions, and that is not a medical decision. That is a personal decision. So my job is just to make sure that they realize, make sure your partner has been screened so you can realize if it's totally irrelevant and move on, or if you want to have a conversation with a genetic counselor and think about IVF.
And then lastly, I just want to ask you if you have any little bits of advice for patients with Thal who might be a little nervous and they want to have biological children. Maybe they're nervous or struggling or anything like that. What's your advice to them?
Plan ahead if you can. Not everybody has that luxury, but if you can plan ahead, make sure that you've seen the cardiologist, gotten those tests and gotten that clearance. Have your iron under good control in the long term, because once you do those things, you start to get closer and closer to what pregnancy from conception to the actual process is like for people who don't have to deal with thalassemia, in terms of your risks, in terms of what medicines you have to deal with. And so if you have the luxury of planning ahead, do so. And the second thing I'll say is that if somebody's telling you that you absolutely shouldn't get pregnant or can't get pregnant, or it's like a crazy risk for your health, stop and hear why they're saying that. Maybe you're a person who has that condition, pulmonary hypertension I mentioned, and there's something that's really important to address. But it is also very possible you're talking to somebody who does not know about thalassemia and is giving you inappropriate counseling. And so I think that's one of those times in life where even if it's a big trek for you to go and talk to somebody who's more experienced with thalassemia, it may be worth it, because I've definitely had people counseled quite inaccurately who are otherwise getting good care because it's just there's not a good paper to read. So the local doctor has worked really hard to learn all the things and just doesn't realize this is okay.
Thank you so much for joining us, Dr. Langer. I was so excited for this conversation, and you did not disappoint. Really invaluable to have a hematologist perspective with insight and specialty in feminine care.
Thank you so much for having me. I think it's really great to start these conversations so that people can figure out how to advocate for themselves and have that chance to plan ahead.
Thank you all for joining this episode of Thal Pals, the Alpha Beta Revolution. I hope today's discussion gave you valuable insights, encouragement, and resources as you navigate your own journey. Be sure to share the show so we can continue exploring topics that mattered most to our community. Until next time, take care.